We want to think now about glomerular filtration rate and how this can be altered in pathological processes. So first of all, let's remind ourselves a little bit about the physiology of glomerular filtration. Well, you might remember that we have these capsules in the kidney, about 1 million of them per kidney. The Bowman's capsules. And this is where glomerular filtration takes place, because going into the capsule we're going to have a blood vessel. Blood vessel going in here, and this goes in and round here. And out again at the other side. And in here we have a complicated network of capillaries, which I'm going to grossly simplify. There we have the capillaries. Now it'll probably help if we colour this in a bit so we can see what we're doing. So here's the arterial supply here. This is the venous drainage on this side. Of course it's not venous drainage, it's still an arterial. And then these are the capillaries. The capillaries of the glomerulus. So the blood is going through these glomerular capillaries. So here we have the blood in the capillaries of the glomerulus. Now the ball of capillaries is called the glomerulus. That is the ball of capillaries. The whole thing, this whole bit here, the capsule and the capillaries, is called the renal corpuscle. The efferent arteriole is taking blood away from the glomerulus. The afferent arteriole is taking the blood into the glomerulus. That's the direction of the blood flow. Now there's a parietal and a visceral layer. So the parietal layer is round here. This is the parietal layer. Just here, round about the outside of the capsule, the capsular parietal layer going round the outside. The visceral layer, that is the layer in here, actually surrounds all of the capillaries. So the visceral layer is made up of these cells called podocytes that surround the capillaries. So this pen is a capillary. The podocytes of the visceral layer surround it like my fingers. They wrap round about it. And then this is the start of the nephron here. That is the proximal nephron, the start of the nephron. Now the process that goes on here is ultrafiltration. That is the name of the process. So ultrafiltration is going on. So what happens is there's filtration from the capillaries into the glomerular space. So we have filtration into the glomerular space. And this glomerular space is called Bowman's space, or the capsular space. And this space is continuous with the capsule here. So there's going to be a process of ultrafiltration from the capillaries into the capsular space. So glomerular filtrate will be formed going into the capsular space around here, and this ultrafiltrate, which of course is now glomerular filtrate, is going to pass around and down into the proximal nephron. So the glomerular filtrate is being formed all the time. This is the process of glomerular filtration, and the glomerular filtration rate should be about 125 mils per minute. Now there is a little bit of latitude allowed on that, plus or minus 20 or 25 mils will be acceptable, but that is the glomerular filtration rate. So the blood is arriving via the afferent arteriole, going through the glomerular capillaries, draining via the efferent arteriole. At least any components of the blood which do not enter the glomerular filtrate are draining via the efferent arteriole. And then this glomerular filtrate is being formed. And as it goes through the nephron, the selected components will be reabsorbed, and the components which we don't want will be excreted in the urine. But the problem is, in chronic kidney disease, the glomerular filtration rate will be lower. There's going to be lowered rates of glomerular filtrate formed, reducing overall renal efficiency. Now the glomerular filtration rate will vary depending on the size of the person, the body surface area, but we normally say 120 mils plus or minus 25 mils of glomerular filtrate per minute. This is every minute, so this works out at about 180 litres a day of glomerular filtrate being formed. And that's for an average sized person who apparently has a body surface area of 1.73 square metres. Now, the question is, how do we know what the glomerular filtration rate is? Well, we can directly measure it using things like inulin, but it is quite difficult. So what we tend to do is we estimate it. We estimate it. And we estimate it based on the serum creatinine. Based on the serum creatinine. So what is the serum creatinine in relation to the body surface area? This is how we estimate glomerular filtration rate. So we estimate serum creatinine, the amount of creatinine in the blood. Now this is going to vary with age and sex and race to some extent, and with weight. But we do have ways to estimate this. Now we could use urea, because of course the kidneys are filtering out urea. But urea is not such a good indicator of glomerular filtration rate. It'll be increased if we eat more protein, for example. It will also be increased in many disease states where the patient becomes catabolic and is breaking down tissues. Or it'll be reduced in liver failure, or if the person's not eating, or if they're anorexic. So serum creatinine is a good one to measure. Serum is the amount of creatinine in the blood. The serum levels of creatinine. Now creatinine itself is produced by the muscles. So here we have some muscles which are always producing, the skeletal muscle here. And these skeletal muscles are always releasing some creatinine into the blood. So the muscles will be releasing creatinine into the blood. This blood, of course, will flow through the kidneys as the creatinine enters the blood in the afferent arteriole and will be filtered out by the kidneys. And the creatinine is very well filtered by the kidneys, so the creatinine will end up here in the glomerular filtrate. And as the creatinine goes through the nephron, it is not significantly reabsorbed, so it will be excreted in the urine and we'll get rid of it. We'll get rid of the creatinine. So with good renal function, we're getting rid of the creatinine effectively. Now, creatinine is actually a breakdown product of creatine phosphate, sometimes called phosphocreatine. And this is a phosphorylated creatine molecule. Don't worry too much about that. It's the way muscles use energy. It's a high energy fuel that the muscles use. But the creatinine is a breakdown product of the creatine. So the creatine physiology is going on in the muscle, but creatinine is released as a waste product into the blood to be cleared by the kidneys. Now, the amount of creatinine produced will vary. If someone is very muscular, then they'll produce more because they have a greater muscle mass. So the trend of the creatinine levels in the blood is probably more important than the overall levels in some respect. So more muscle mass people will have more serum creatinine, and low muscle mass, the elderly for example, will tend to have lower levels of serum creatinine. Now, if the renal function is impaired and lower levels of glomerular filtrate are made, there's lower levels of glomerular filtrate made, then that means there'll be less creatinine in the glomerular filtrate. Less creatinine will be cleared from the body because there's reduced renal function. And that means that more creatinine will be left in the blood, so the serum creatinine levels are going to rise. They're going to rise. But actually, the body's quite good at this. And we have a look at this graph here. Now what we have here on this graph is we have the serum creatinine levels up here. It's the amount of serum creatinine. And down here we have the glomerular filtration rate, which is measured in mils per minute per 1.73 square meters of body surface area. That's the whole body surface area in an average sized person. So hopefully your levels of glomerular filtration will be very high. We want high levels in young fit people, 120 mils or more per minute. But as these levels start to drop, as glomerular filtration levels start to drop, you can see here now, for example, that glomerular filtration rate has dropped to 80 mils of glomerular filtrate produced per minute. But the serum creatinine has not risen significantly. It's still in this kind of range. This red line is the range. It could be anywhere in here. And even when the glomerular filtration rate drops to 60, then even then the serum creatinine is not raised significantly. So it's only when the glomerular filtration rate drops off quite dramatically that all of a sudden there's a decompensation and serum creatinine rates will rise quite rapidly. It's quite clever the way the body can actually adjust itself for varying levels of glomerular filtration, even if the levels of glomerular filtration are compromised. It can still compensate to quite a large extent. So we can estimate, as we've seen from this, we could read this graph the other way around, of course. We can take the serum creatinine and we can use that to estimate the glomerular filtration rate. Now, I'm not going to tell you how we do this. The biochemists have a formula for this. They take into account age and sex and race and sometimes weight, body surface area, the size of the person. And once they know the serum creatinine, in the context of that person, they can estimate what the GFR is. So the glomerular filtration rates that we use clinically are actually eGFR, estimated glomerular filtration rates. But they're clinically useful, so we carry on using them. Now, the good points about using eGFR, estimated glomerular filtration rate, to assess your patient's renal function is that we can recognise deteriorating function early. If the patient's developing CKD, chronic kidney disease, we can recognise it early. So, for example, if they're diabetic, we can recognise it early and we can bring down their blood sugar levels. If the person's hypertensive, we can recognise the hypertensive induced chronic kidney disease at an early stage, and we can give hypotensive medication to bring it down. We're quite good at that. So we can recognise the development of renal compromise, the development of chronic kidney disease at an early stage, and we can usually or very often prevent it from deteriorating as we intervene to correct the disease process which is adversely affecting the glomerular filtration rate. So we can intervene to get rid of this pathological process, or any pathological processes we can identify that are compromising renal function. And the other big advantage of this is it helps us to stage chronic kidney disease. We can actually stage chronic kidney disease, which is very useful to give this stages. Now, stage 1, there can be some minimal kidney damage, but the glomerular filtration remains above 90. And the estimated GFR, if the estimated GFR is above 90, most biochemical labs will just say it's above 90 and that's considered normal, the patient's asymptomatic. But if the GFR drops to 60 to 89 mils per minute, or that's the estimated GFR, the glomerular filtration drops, then the kidney damage might be slightly more significant. The patient's now in stage 2 chronic kidney disease, but they'll still be asymptomatic. And thankfully most of these do not progress. It's only a minority that progress, thankfully. Stage 3A, there's moderate kidney damage. GFR can go down to 45 to 59, but the patient's often usually asymptomatic. The patient's asymptomatic. And we did explain that before. So glomerular filtration rates of say 40, then even then the creatinine is not raised significantly, as we saw on this graph. So if the GFR was 50, say there, then the serum creatinine would not be significantly raised, which is good. But if the glomerular filtration rate keeps dropping, say to 30 to 40, then this is an indicator of moderate kidney damage. The patient has chronic kidney disease caused by kidney damage and kidney injury. And they may develop anemia at this stage, that's possible, so it's always worth checking, because remember, of course, it's the kidney that produces the erythropoietin that stimulates the erythropoiesis, which is the process of forming red blood cells in the bone marrow. And thankfully, as we've said, most patients do not progress on to the more severe stages. But of course, some do if the pathological process is ongoing or it is not corrected. If the diabetes is not recognised, for example, it's a very common cause of chronic kidney disease, or if the hypertension is not recognised, or if polycystic kidney disease is progressing, then it can become severe and the glomerular filtration rate can start to drop. And when we get into these lower ranges of glomerular filtration rate, we can start to get electrolyte derangements. The patients might not be able to get rid of their potassium and their sodium effectively, and they can become hyperkalemic, for example. And then the final stage, stage 5 of chronic kidney disease, when the glomerular filtration rates are very low, GFR of less than 15, then the patient gets significant symptoms and complications. And unless we give them renal replacement therapy, these patients are likely to die from chronic kidney disease. So we can deduce all that if we know a little bit about our patients. We understand the concept of glomerular filtration, the importance of the glomerular filtration rate to maintain renal function, how reduced glomerular filtration rates will result in increased serum creatinines, and how we can use this to provide us with an estimated glomerular filtration rate to help us prevent chronic kidney disease developing, and to help us to stage chronic kidney disease should it have developed.